Started. We're very excited. Thank you for joining our pepper rounds today. I'd like to introduce Dr. Victoria Powell. She is a clinical assistant professor of medicine at the University of Michigan and Pepper Center RECC scholar. She completed internal medicine residency at Johns Hopkins Hospital and hospice and palliative medicine fellowship at the NIH Clinical Center. Clinically, she practices inpatient and outpatient palliative medicine at the Lieutenant Charles Kettles VA Medical Center in Ann Arbor. Her research interests are integrative treatment methods to address psychosocial, existential, and spiritual distress in people living with chronic pain and serious illness. So welcome, Dr. Powell. Thanks so much, and we'll let you take it away.
Well, thank you. I'm very excited to be here. So just briefly, here are my funding sources. No conflicts, but I absolutely will be discussing some off-label use of drugs. So in today's talk, I'll be giving an overview about how psychedelics might work, what they might work for, and what are some special considerations for older adults. So throughout this presentation, I tried to weave in some examples of 3 distinct compounds that have some psychedelic properties that have been tested in some different conditions. And these are ketamine, MDMA, which is also known as ecstasy, and the A stands for amphetamine, and psilocybin. So these drugs are somewhat different from each other, but I think that they each illustrate different facets of modern psychedelic research. So I always think it's so interesting when people describe, how did you get interested in a certain topic? How did you decide what to work on? And I think, the way that I became interested in psychedelic assisted research in general, I'm a palliative care physician. And early in my medical training, I noticed that there are some people who near the end of life or when dealing with a serious illness suffer from this existential and spiritual distress. So by this, I mean crises of meaning and purpose, legacy, death anxiety. And it really is one of the most profound forms of suffering one can witness. It greatly complicates pain control, family dynamics, really just the whole clinical picture. And I felt that there was really little that I or anyone else could do to help these people. Listening and holding space can help, but that has its limits. They were really too sick to benefit from like traditional evidence-based psychotherapy. And often what I would see happen is that they end up on these high doses of pain and anxiety medications, which sedated them, but didn't treat the underlying problem, was that they were terrified of when confronting their own mortality. And so then I stumbled across this study that came out in 2016 from Roland Griffith's group at Johns Hopkins. This came out when I was a resident at the same institution, but interestingly, I didn't hear about it until a couple years later. In this study, they tested psilocybin-assisted treatment in a sample of people with advanced cancer and co-occurring anxiety and depression. And what they found was not only did psilocybin-assisted treatment improve anxiety and depression, but there were pretty profound effects on measures of feeling that life had meaning, death acceptance measures, and about 2/3 of the participants said that it was one of the most personally meaningful experiences of their life, similar to the birth of a child. So while we'll talk about the risks, I also want to make sure we're going to touch on some ways that older adults could stand to benefit. And because dying is something that, and serious illness is something that disproportionately happens as we age, it's possible that existential distress may also accompany that at times. And so older adults could potentially stand to benefit disproportionately from this work. Now, this study, it was not focused on older adults specifically. And then, so there are a few things recently that I've found that have really piqued my interest in this topic with older adults. The first was when I was doing some preliminary research for a VA Career Development Award application on the topic of ketamine-assisted treatment for people with co-occurring chronic pain and depression. And so this is data from all veterans that received IV ketamine for treatment-resistant depression, just some basic descriptive information. I was really fascinated to see that the upper age limit is 86 years, and this was even a couple years ago. Things might have changed a little bit since then. And almost 15% of them were 65 years old and above. So some older adults are already receiving some of these psychedelic type treatments. The second factor was this case that I learned about recently. So it really highlighted that there's an unmet need for understanding these substances in older adults better, and that there are some competing forces at play. So Michael Pollan wrote this best-selling book, How to Change Your Mind, came out about 5 years ago. It was about the history of psychedelics, some research into their potential, as well as his own personal experience while researching this book. And because he's such a popular author, I think this book really got psychedelics on the radar of many people. It also seemed to spur some people his age and older. Now, he was around 60 when he wrote this book and when he came out, spurred them to experiment with psychedelics after reading. Of course, the people that we're calling older around his age are in the baby boomer generation, who some of them already had experience with these substances and maybe wanted to revisit them at a different phase in life. And one of them was this man, is a 74-year-old man named Richard Burton. He's a grandfather and former public defender who, according to reporting done by the New York Magazine, he engaged the services of an underground psychedelic guide and took psilocybin-containing mushrooms. Quote, so Richard shows up on the morning of October 25th, 2018. He gets ready for his session, takes the mushrooms, then lies back and puts a mask over his eyes. Less than an hour goes by and Richard's heart stops. The autopsy report initially said probable acute psilocybin cardiotoxicity, but soon after, the coroner was called by an interested physician. Quote, he or she educated the coroner about mushrooms, and the coroner looks up some of the studies himself. After reading these, the coroner changes the cause of death. He concludes the mushrooms didn't directly cause his death. Instead, he decides it was Richard's heart problems that killed him and the mushrooms contributed. And then it turned out that the physician who called is the U.S. medical director for a company that provides boutique ketamine therapy and is planning to offer psilocybin if it becomes legal. So clearly that person had a vested interest in making psilocybin look as good as possible. And so as we move forward, it's going to be very important to scrutinize the safety data, knowing that people who stand to gain financially and those market forces, just like any pharmaceutical product, are working here too. So with that in mind, I'm sure that almost everyone on this call has no doubt seen or heard exciting news and headlines about psychedelic drugs. There's just been this explosion of psychedelic drug-related research for many conditions in the past few years. And so far, S-ketamine, which is the S enantiomer of ketamine, it's the only psychedelic drug to have an FDA-approved on-label indication, which is treatment-resistant depression. So as of early 2023, when I'm putting together this talk, I decided to do a little search on clinicaltrials.gov just to see what's out there, what's been registered. And, interestingly, I found over 100 studies each on psilocybin and MDMA, and then 1,300, actually over 1,300 investigating ketamine. Now, these studies are investigating not only PTSD and depression, but just a wide range of other conditions, substance use disorders, chronic pain, cluster headache, even anorexia. As I touched on earlier, they're also being investigated for things that we might not necessarily consider a disorder in the traditional sense, things like existential distress states, demoralization, end-of-life anxiety. So now I want to briefly talk in general, see, one second. Okay, so briefly in general, what are the current thoughts regarding the mechanisms underlying psychedelics, and why have they been tested, or why are people interested in them for so many different conditions? So, just to catch us up to speed on terminology, I think it's surprisingly tricky to define what a psychedelic is. So I'm going to propose that a psychedelic is a compound that, when consumed, can result in a mystical type of experience that I'll define in a minute. So we can broadly put them into two categories: the classical and atypical. So classical are those psilocybin, LSD, those that exert effects primarily felt to be through this activation of a particular particular serotonin receptor, 5-HT2A. So many of them are from natural sources like psilocybin from mushrooms, mescaline from cacti. LSD is a semi-synthetic compound. And then there are these atypical psychedelics. These are drugs that occasion a mystical or psychedelic experience in some form, but have a markedly different mechanism of action and have some qualitatively different, the experience seems to be qualitatively different. Ketamine and MDMA are two examples of drugs that are being heavily investigated, and I'll talk a little bit about each of those in more depth subsequently. And so what they have in common is that they seem to be able to occasion this mystical experience. So what do I mean by this? Mystical experiences are natural phenomena that occur in some people not involving substances at all. They're documented across cultures, often in a religious or spiritual context. For example, prophets, shamans, other cultures, wise men and women. So some qualities that mystical experiences share include this sense of unity or interconnectedness, accompanied by feelings of reverence, a deeply felt positive mood, feelings of love, ineffability or the inability to put the experience into words, and this noetic quality, which is a feeling of encountering absolute or ultimate truth. So in describing this, I want to be clear, I'm not suggesting that anything supernatural is actually happening. These are just qualities that mystical experiences share, and these are experiences that participants report under the influence of psychedelics. So we spoke briefly about psilocybin already, just wanted to share a little bit more. This is a compound that's found in several different types of mushrooms. They've been used by indigenous people in Central South America for hundreds, probably thousands of years. Seems like they first came into Western, kind of the Western civilization by a Spanish Franciscan friar who came to Mexico around the 1500s and really became an ethnographer, lived with the Aztec people for decades. He wrote about this mushroom that, when translated from Aztec into English, is God's flesh. Now, it wasn't until the 1950s that a sample was acquired from Mexico and taken to Albert Hofmann, who was the chemist who discovered the effects of LSD and tested it on himself in the 40s. Now, he did ingest some apparently to confirm that they were real, and eventually he figured out the active ingredient and named it psilocybin. So this is a graph. It's a little bit out of date, but just it kind of gives you a sense that there were many studies published on psilocybin over time, starting in the 50s. Many psychedelics, including LSD and psilocybin, were heavily investigated, 50s, 60, 70 years ago, but they weren't exactly what we would consider high quality studies. A lot of them really amounted to, hey, let's give this in a variety of conditions and circumstances and see what happens. So then the Controlled Substances Act was passed in 1970 and basically it made it very difficult to conduct any research. And there was also this societal stigma and association with counterculture that just made it kind of like it just seemed like the juice wasn't worth the squeeze of doing this research anymore. Then around 2006, some pioneering researchers started to publish studies in human volunteers in a few different conditions, small studies. And now we're in the midst of what's been called the psychedelic renaissance. So psilocybin is still a Schedule I drug federally, meaning that it has no officially recognized therapeutic value. However, it is rapidly becoming more of a gray zone. So many cities, including my own city of Ann Arbor, have passed decriminalization legislation. But Oregon took it one step further. So in 2020, Oregonians voted that psilocybin be made available for therapeutic purposes. And now Oregon has become the first state in the US to create this regulatory framework for psilocybin. So in January of 2023, Oregon started taking applications for a psilocybin services license. So the delivery is going to be based around the psychedelic-assisted therapy model, where a client meets with the guide prior to the session where the drug is administered to prepare. Then the session happens with the guide physically present the entire time, followed by an integration session or sessions which appear to be optional. So how might psychedelics work? There is accumulating evidence that on a psychological level, increases in flexibility likely play a role in understanding how something with these acute effects could produce some enduring changes. So the psychedelic compound occasions this mystical type of experience that's accompanied by a sense of insight. Several studies have looked at some pathway analysis, finding that increased psychological flexibility mediates the relationship between the experience under the influence of the substance and improvement. So I'm using this term improvement as intentionally vague because the process may be therapeutic for many conditions. And the thought is that, you probably know that there are many conditions that are characterized by maladaptive thoughts, habits, inflexible beliefs. The mystical experience might produce this increased flexibility that persists for some time, allowing an opportunity for someone to reframe their situation, reframe their thoughts in a way that could be difficult or otherwise impossible to access. So let's move into what's possibly relevant for older adults. So wanted to talk about safety considerations that really broadly fall into two categories, cardiovascular and then psychological. And I think that there are some real concerns here that have me worried. Psilocybin, ketamine, MDMA, they have the sympathomimetic effects. So they have stimulant-like effects. They increase blood pressure, heart rate, nearly everyone. And in some people, it's been enough to require medication for hypertension in the trials. In studies of MDMA for PTSD, where the mean age overall has been about 40, some subjects experienced increases in ectopy that required them to be monitored overnight. Psilocybin also seems to prolong the QT interval. It's not really clear at all what the burden of cardiovascular disease needs to be before these drugs would become contraindicated or relatively contraindicated, or perhaps some type of stratification, risk stratification, the way that we do with surgery, or maybe enhanced monitoring. All of that is completely unclear at this point. But I wanted to give you a sense of the magnitude of cardiovascular effects. So this is data from that Griffith psilocybin study I touched on earlier, that small RCT for people with anxiety and depression with advanced cancer. So these are graphs of changes in blood pressure and heart rate over time. Now the mean age here was 56. So they're not exactly an older population the way we think older, above 65 or Medicare age. There was a high dose psilocybin condition and a low dose condition. And we see that in the high dose condition, blood pressure and heart rate increased significantly and persisted for about 6 hours. Now, continuing with psilocybin, this was one of the very few studies that's contained majority of participants above 55 who have medical complexities. This is a very small study of 18 participants that focused on men living with HIV who were diagnosed before the availability of protease inhibitors around 1996. So their age range was 50 to 66, a mean of 59. And about 1/3 of them each had hepatitis, kidney disease, cancer, or chronic pain. So it was a pretty medically complex and chronically ill group, especially from a clinical trials perspective. They recruited participants that were demoralized, which is an existential distress state defined as a sense of hopelessness and a loss of meaning and purpose in life. So this is correlated with depression, but it's considered a distinct construct, kind of similar to the way that loneliness is a distinct construct that can be studied, but is correlated with depression. Now, notably, about 90% of the participants felt less demoralized after the intervention. But what I really wanted to talk about was, here's a graph of the changes in blood pressure over time. Gives you a sense of how systolic blood pressure changed during the course of the psilocybin experience. So they started off with a mean of around 130, then went up and stayed up for several hours. 4 of the 18 developed severe hypertension, so higher than 180 over 110, but it was self-limited. So moving on to the psychological and behavioral safety concerns. So the first one that I think a lot of people think about is, does this increase the risk for a psychotic episode in people that are otherwise vulnerable, or a manic episode? And the answer is possibly. I think there have been some reports of mania being precipitated in younger individuals. We're really not sure if that is the same for older adults at all. What we can be pretty certain of, and I think is something that requires consideration for everyone, not just a theoretical person who might be at risk for psychosis, is that people are extremely vulnerable under the influence of these substances acutely. And there have been very credible reports of participants having disturbing experiences with their therapists, some of whom have used some pretty unconventional techniques, like a lot of physical contact. So this is a still from a video recording of a participant in one of the MDMA trials for PTSD. She's not older, but I think this is really important. I wouldn't show something like this if it weren't released by the participant to the media. She was hoping to share her experience as a warning to others. So the therapist, she's in the middle, the therapists are on both sides. They're a married couple, and they were, with this coming out, these individuals were barred for participating in any other clinical trials for MDMA. But it is a real concern. Again, overall, I would say that the substances seem to be pretty safe for younger people and people with few comorbidities, but it's just very understudied in older adults and people with multimorbidity. But I don't want to paint too negative a picture about the safety concerns. But I want to be realistic when presenting this. And as I mentioned earlier, there are several studies demonstrating benefit for existential distress, concerns related to end of life, and grief that I'll talk about in a bit more depth. And I wanted to say one thing. There's an ongoing pilot study examining psilocybin for neuropsychiatric symptoms like mood changes, irritability, aggression in early stage dementia. And the thought is that perhaps psilocybin might not only help with those behavioral changes, but could perhaps be actually beneficial for dementia. And that's based on a fairly robust literature that demonstrates increases in neuroplasticity and neuronal connectivity. It's really out of the scope of this talk, and I don't want to say too much about it because I'm not able to identify any studies that have been conducted in humans, but it just wanted to let you know that that's currently recruiting. So just to change gears a little bit to talk about ketamine, as ketamine has also been investigated in distress states at the end of life. So just a brief timeline of ketamine. A little over 50 years ago, it was FDA approved as an anesthetic. The first RCT of ketamine for depression came out a little over 20 years ago, and now it's currently widely in use for treatment-resistant depression. S-ketamine, or Spravato, is the intranasal branded formulation, but the that's the S enantiomer, but IV ketamine, the racemic mix, is frequently used. It's relatively inexpensive, although I heard that there is an ongoing shortage now. It's typically given IV. It can also be given IM or sublingually. It's pretty poorly absorbed orally. And again, to my knowledge, ketamine is the only agent with psychedelic effects that's not a Schedule I compound. So there's been a couple of interesting studies in ketamine that, again, while not necessarily intending to study older adults, ended up including mostly older adults. So these are two very small studies of patients receiving hospice care, so near end of life, who had symptoms of depression or anxiety. These people were given oral ketamine for some time, up to a month. And as you might imagine, for a hospice population, the mean age was in the 60s with upper age range in the upper 80s. There were no serious adverse events in either of these studies, but they weren't really, they weren't RCTs. They were retrospective or just, very small, uncontrolled studies. But Some side effects that came out: diarrhea, insomnia, trouble sitting still, no major adverse effects. And, this is interesting. It's an extremely ill population who might stand to benefit without major adverse events showing up, but certainly more work is needed here. So I just wanted to take a second to say, one of the things that I found very interesting and important to highlight is that in nearly all studies of ketamine have really looked at just the effects of ketamine, the drug itself, especially these high quality RCTs for treatment resistant depression. So it's generally not combined with psychotherapy, although a couple of studies have looked at that. Again, the setting that ketamine is given is typically a very medical type of setting. So at the Ann Arbor VA, for example, it's given in the PACU. Now, this is very different from where the studies of psilocybin and MDMA have been conducted. They've been almost entirely in a comfortable room that is kind of looks like a cross between a hotel room and a talk therapy room. The guides are present, the therapists are present the whole time. They're wearing normal clothes, not scrubs typically. They have playlists of relaxing music, eye mask, just other things to keep someone comfortable. It's not very much a medical setting. It's more of a psychotherapy setting. Now, just to talk about MDMA a little bit. Again, this is a substituted amphetamine. It's also known as ecstasy. It was first synthesized in the early 1900s, but the person who really made it famous, made it well known, is an American chemist named Alexander Shulgin. He synthesized it in the 70s and took it, felt that it had potential, gave it to a psychologist colleague who then used it as an adjunct to psychotherapy and shared it with other psychotherapists. Interestingly, Shulgin, he's quite an interesting character. He and his wife later published a book called PCAL, which stands for Phenethylamines I Have Known and Loved, which describes their experiences synthesizing and using MDMA and other similar compounds. So like the other compounds I've talked about, it has a complex mechanism of action. It's a amphetamine. It's a serotonin agonist. It causes release of oxytocin, prolactin, cortisol. It has those, again, stimulant effects. I think I found a quote from Ralph Metzner, who was a psychologist and an early proponent of MDMA-assisted psychotherapy, who distinguished it from other psychedelics by saying, quote, "The most frequently reported characteristic that distinguishes MDMA from LSD type experiences is the emotional communion, the oneness, the relatedness, the emotional openness." So MDMA increases prosocial feelings and behaviors. This may assist with reprocessing of traumatic memories under its effects. And so, certain psychedelic drugs, including MDMA, have been designated by the FDA as breakthrough therapies, which means that they're on a fast track process of development and review. Breakthrough therapy designation is given to compounds that are, quote, "intended to treat a serious condition and preliminary clinical evidence indicates the drug may demonstrate substantial improvements over available therapy." Now, in this phase 3 study of MDMA-assisted therapy for PTSD, they did find a very large effect size, Cohen's d of over 0.9. And it's expected that the organization who sponsored these trials is going to submit their data to the FDA and request approval for PTSD this year. So later this year, we're expecting that they're gonna request approval. No idea if it's going to be granted, but they're going to start that process. So like ketamine and psilocybin, MDMA has been investigated to a limited extent in patients with life-threatening illnesses and associated anxiety and depression. There was a very small pilot RCT with a mean age of about 55, looked at MDMA-assisted therapy for people with anxiety associated with a serious medical illness. So they did find, it was underpowered. It was only 17 individuals, and they did find a trend towards a benefit. You talk about the safety. So as expected, MDMA increased heart rate, blood pressure, and body temperature, although body temperature was the only one that met significance. And it wasn't a dangerous body temperature, but there was a significant difference there. So, notably, a later publication came out that focused on qualitative outcomes of this pilot study. Quote, specifically, participants explored what they felt were important elements of the therapeutic process, including processing trauma and grief, and exploring mystical and existential experiences, engaging with the present moment, and with reduced physiological activation, and facing illness and existential fears. Now, I think when we talk about this idea of a mystical experience, it still feels pretty abstract. I think when you read what some of the participants themselves have to say, I think it becomes a little more clear how this could have therapeutic potential. So, just wanted to share a few quotes with you. It wasn't drama. It was just the human condition and illness and death. I was seeing my lifelong inquiry into life and death from this very expanded place. And it's as if I had these invisible lines of architecture of how consciousness works. Someone else said, I feel so much awe. It feels very spiritual and divine. I went to this visual place with light pouring down on it, which is my present space, and it's just me, and I'm healthy. And wanted to share another quote from a participant who received psilocybin, who had a serious illness and anxiety and depression related to that. Now, this isn't from the Griffith study. This is from another study from NYU researchers that came out almost exactly the same time. And this is actually a long-term follow-up. So 2 years after receiving psilocybin, there was still a beneficial effect, which is very interesting. This person's quote, once the thought that cancer is a part of your life becomes woven into the fabric of your being, you realize that this or something similar awaits many others who are unsuspecting. This compels you to relate to others from the perspective of compassion due to the changeable and temporary nature of our sense of who we are. Radical change is just around the corner, regardless of how certain we are of our current state. We are children in our understanding of life until something reaches into your heart and announces itself. I understand the life process to be one of realization of our divine nature. This doesn't include any supernatural creature. It's a process of remembrance. Now, I wasn't able to find any qualitative studies from participants that received ketamine for end of life or existential related or distress, but I was able to find a couple of qualitative studies of people who received ketamine for treatment resistant depression. And I think these really highlight how that increase in flexibility might allow some reframing of those maladaptive thoughts or habits. So, I felt like I was able to deal with the issues in a self-nurturing way. I just accepted all of the stuff that happened, and it's not the end of the world. I don't need to hate myself over things I haven't done right. It's changed the way I perceive my own brain and the way I experience reality in a more realistic way. I had a strong negative internal dialogue, and I didn't see that it was a problem with my brain and thought it was a problem with reality. I think after that experience, I am open to the idea that my brain is actually processing things in a negative way. So just to summarize, I just have a couple of points that I hope you'll take away from the presentation. Psychedelics show promise, some really, really tremendous promise, I think, for depression, PTSD, and distress related to end of life or serious illness. Because psilocybin will be allowed soon in Oregon, if not already right now, we might see people traveling to Oregon. And I understand Colorado also passed one of these provisions too for psilocybin-assisted treatment for various conditions. And that having at least some characteristics of this mystical experience might be the key for improvement that could work through this increased psychological flexibility. And that may explain why so many diverse conditions have been tested and found to be helped. This increased flexibility and ability to rethink maladaptive cognitions and habits, this underlies many distressing conditions. There is some real evidence of increased cardiovascular risk. Very few older adults or people with complex medical conditions have been included in the trials. Can't offer any parameters right now of when that risks outweigh the possible benefits. And there is extreme psychological vulnerability under the acute influence of these substances that is really going to require us to think deeply about how we're going to best protect people out in the wild if these were legalized. And then finally, in conditions that affect older people disproportionately, because older people are disproportionately likely to die, they may disproportionately stand to benefit. So I'm thinking especially of the case of existential distress states. So just wanted to wrap things up by saying thank you to my mentor and advisorship team. Not everyone here is on my official team, but all have provided invaluable mentorship and advice in some way, and want to say thank you. I want to mention that the pilot data that I talked about came from work with Dr. Pfeiffer's support, and I would be happy to hear people's thoughts, or maybe try to answer a few questions, or just maybe have a little conversation in the time that we have left.
Well, thank you very, very much. I'm sure that we do have some questions or comments from our group. Let's just see. I'm going to check if you want to put your question in the chat or raise your hand. Keith, do you have a question for Dr. Powell?
Hi, yes, I noticed that a lot of the treatments were for resistant depression. Depression is difficult to treat. I'm wondering, are there other preliminary uses for the psychedelics? For example, let's say you're not clinically depressed, but you're feeling certain symptomology of depression, such as loss of interest, anhedonia, things like that.
So kind of like so people who might be more like us, like have some symptoms of major depressive disorder, but might not meet the threshold for diagnosis.
For
like
the
could
DSM diagnosis, yes.
Yeah, I'm not aware. Nothing comes to mind that has looked at that specifically. I think that would be probably something that would be less, that the FDA would probably be less excited about, because really what they want to see are they've been psilocybin, MDMA have been designated breakthrough therapies for treatment resistant depression, because they seem to show a great improvement over prior or other treatments, and so because they're, to say, I truly don't know, but I would think that would be something that maybe that would be a type of study that would be conducted after these are, if they were legalized, or after they would be approved for treatment resistant depression, the more severe cases at first. But if anyone else has any insight or thoughts into that, I'd be curious too.
We have a question or comment from Sarah Patrick. Go ahead.
Thanks so much. And Dr. Powell, this is a really great presentation, very helpful, very timely in Illinois, as certain legislation is being reviewed in this General Assembly. So thank you very much for that. I'm curious about the one case that you had shared where there might have been some reason for the provider to basically change the death certificate. I'm curious what you can share about who are the manufacturers or the different groups that are bringing drugs forward. What should we be looking for in terms of those types of pharmaceutical either purveyors or producers? For instance, when we legalized cannabis in Illinois, one of the big issues was related to equity and making sure that people who had been disproportionately affected by non-legalized recreational cannabis that could actually get into the business of legal recreational cannabis. And I'm just curious what you could just share about who's producing these drugs, or who's looking at it from a market perspective. Thank you.
Sure. I have to say, I do not know who is producing them. Because many of them are from naturally occurring compounds. I don't know if I truly don't know. As far as what to look for, what my understanding is that there are you probably have seen there are many of these ketamine clinics that have popped up around Michigan. There's a ton of them. I think there are in other states too. And my understanding is that these clinics are just heavily backed by venture capitalists. There's a lot of interest from the Silicon Valley, kind of funders group, that these clinics are really trying to poise themselves at kind of, get a good market share, so that if psilocybin and these other psychedelic compounds become legal, they're going to be ready to kind of pounce on that the demand from the market. And as far as what to look for, I think we should just look at it very similarly as we would with any other pharmaceutical company. These are pharmaceutical companies have enormous profits. They have kind of look at what people's incentives are. They have an incentive to get their drugs approved and keep them on brand name for as long as possible. And they have an incentive to make them look as good as possible. I think that I don't see necessarily anything too different about it, about these substances than any other compounds.
Thank you.
Dr. Powell, there's a couple questions in the chat. One is, has there been any research or inquiries into psychedelic therapy and chronic pain?
That is interesting. I actually am interested in conducting a study with ketamine looking at chronic pain. There is a pretty robust literature that looks at just ketamine for chronic pain, and the consensus is that it helps, but the effect really pretty rapidly attenuates over a couple of weeks. It doesn't really produce any lasting changes. But chronic pain is one of the conditions that is, if you look on clinical trials, their studies are interested, even if they're not recruiting now, they're looking to recruit in the future. There is quite a bit out there. And I think for people, for people who have chronic pain with, with a lot of the maybe maladaptive thoughts or cognition surrounding it, people that have a lot of interference of chronic pain with their daily life, those are the folks that may particularly stand to benefit from those changes and increased psychological flexibility. Maybe we wouldn't necessarily see a reduced pain intensity, but we really could help them have a reduced pain interference with function.
Another question about issues of developing tolerance over time and how that impacts the effect of the drug, and also any sex differences in terms of effect or side effect risk.
Oh, I have not heard anything about sex differences at all, but that is very interesting. If for developing tolerance over time. So this is kind of one of the interesting parts about these compounds, is that they're not given very frequently. MDMA, in some of the studies they gave it once, in some of the studies they gave it twice. For psilocybin, they give it once or twice, but it's not a prolonged exposure, at least with this psychedelic-assisted therapy model. Ketamine is given many times for treatment-resistant depression. Yeah, really, it's unfortunate that it seems to work really well for many people in the short term, and then the effects attenuate over time. And really, the only thing that prolongs the benefit is repeated administration of ketamine. Now, there isn't, as far as the antidepressant effect of ketamine, there isn't strong evidence that attenuates over time, or that people require drastically higher doses. They seem to, we actually kind of looked at this from data with Dr. Pfeiffer that he actually just presented last week, showing that, over a period of at least a year, over 2020, when people were getting this treatment for treatment-resistant depression, the doses changed a little bit, but their PHQ-9, their kind of depression measure scores, stayed better than they were at the beginning. So much there, and really kind of dropped and then continued as long as people were continuing to receive ketamine.
Thank you. Another question, has there been any studies comparing mindfulness or mindfulness-assisted therapy versus psychedelic-assisted therapy? And any thoughts about parallels or shared mechanisms?
Yeah, that is, there have been. There's one study that I know of that was also done by Roland Griffiths, who he's an interesting guy. He actually got into this, got interested in psychedelics coming from the perspective of being someone who had a meditation practice that found it very beneficial. And so there is this kind of network of brain activity called the default mode network. And that's the pattern of activation of brain areas that occurs kind of with the monkey mind that we hear about. And if you've investigated meditation, where, it's just kind of the self-referential, kind of the way the brain networks that are activated during like normal thought. And it tends to be associated with kind of just general feelings of malaise and anxiety. That default mode network is less active in people who are experienced meditators, and it's profoundly less active during the acute effects of these compounds. As far as what exactly that means, it isn't clear, but it does seem like there are very strong parallels between meditation and I don't know if specifically mindfulness, but meditation in general, and the effects of these substances. Roland Griffith's study was looking at the kind of differentiating between the effects of psilocybin in people who are experienced meditators and people who were novice meditators. And now I'm completely blanking on what the outcome was, but that one is something that has been investigated. But certainly a lot more work to be done here.
Great, thank you. Other questions or comments from the group? You're great. I don't see any other hands. So thank you so much, Dr. Powell. It's very, very interesting. We'll have to have you come back with an update.
Yeah, this was fun. I really enjoyed putting this talk together.
Fantastic. Thank you so much.
All right. Thanks everyone for joining. We'll see you next month.
Bye-bye.
Bye. Thanks again, Dr. Powell.